Very good evening to all of you. Regards from Malabar Medical College. Actually, these lights are very bright here, and there are no lights. I am not able to see. Also, is there more lights on that side? So you are the 4 PGs, but you never responded. Only one responded through the WhatsApp group which was created by Srijit. Okay, I was supposed to start at 7:45. It is around 8:10. And good news, you know that after this it is the dinner. And the bad news is you have to tolerate me for another 45 minutes. I will try to reduce it and make it interesting also. So I'm not going into the details of the algorithms, what you have in your curriculum, and what is the present algorithm, what is there. I'll just take you to overall the description of the CPR, and one of the gray areas which you all lack is the electrical therapy, which includes defibrillation, cardioversion, and transcutaneous pacing. So to start with, we give a definition for cardiopulmonary resuscitation. It is a series of life-saving action which follow after cardiac arrest. So recognizing the condition early and identifying the cause is of utmost importance, because time factor plays an important role here. So you should have the presence of mind, knowledge, and the skill to perform these procedures within the stipulated time. Now, the primary concern, as you all think it is the heart, it is not the heart, it is the brain, because you all know that when there is an hypoxia and if it is beyond 4 to 6 minutes, there will be irreversible brain damage. There will not be any use, heart will be beating, and the only use is organ transplantation. So these things are very important, the time factor. So you have to know what exactly to do in this crisis. Now, you can give cardiopulmonary resuscitation by manually and also with automatic machines. So what you see there, it is auto pulse, but these machines are not superior to the manual one because it takes time to fix this under the patient and it is expensive. So if you ask what is the advantage of this is while transporting a patient. While transporting the patient, it's not possible for you to give CPR manually. That will not be effective, so you can use these machines. Have you heard about this term, eCPR? Those are sitting here. Nabil, your name is Naveen. Okay. Any idea? Anyone from the audience, you know about eCPR? Yes or no? No. That's also not there. Should I stop? For that also, the answer is no. eCPR, it is nothing, it's ECMO. See, that is used while transporting the patient. So there is something called eCPR also, but you cannot just put a patient just to make him leave in a eCPR. There are certain criteria to put this also. So guidelines. So which is the guidelines you know of cardiopulmonary resuscitation, which is very, very common? What is it? You have used the mic and see.
AHA guidelines. AHA guidelines.
AHA, American Heart Association. Yes, true. American Heart Association. And which is the guideline we are following at present?
2020.
2020, that's true. So it is 2020, and the earlier ones were in 2015, then 2010. So every 5 years it was getting updated. So I should also say that there is another guideline which all of us should be proud of. It started from the anesthesia team, and it was started in 2017 under the aegis of Indian Society of Anesthesiologists. Presently it is known as Indian Resuscitation Council Federation. So they have included other specialty also into it, and I'm very happy to say that we are a part of ILCOR. So it has got three algorithms. One is compression-only life support, which is very, very popular nowadays. BCLS, that is basic cardiopulmonary life support, and also comprehensive cardiopulmonary life support. So these three, if you look at the guidelines also, they looks very simple, very clear, and it is color-coded. So you should know about Indian Resuscitation Council Federation guidelines also. And that is codes, which is converted in each state into their own language, translated into their own language. So we have, in Kerala there is Malayalam also. And happy to say that it is included now in 9th standard of CBSE. So that is a great achievement from all from the Indian Society of Anesthesiologists as well as from the Indian Resuscitation Council Federation. So by telling this, you should know about what is ILCO. It is the International License Committee on Resuscitation. So this was formed in 1992. It is a forum to license between various organizations, resuscitation organizations around the world. So at present there are 7 organizations that, and as you said, which is more popular, it is the American Heart Association, and rest of the things you can see in that, rest of the 7, and Indian Resuscitation Council Federation is the observer invitee at present. Within maybe in 1 year, maybe less than that, we also will be in the ILCO, and that is a great achievement. And this picture what you show is on the World Restart Heart Day. There was a meeting where Indians, like the Indian Resuscitation Council, which was known as earlier as Indian Resuscitation Council, this is a meeting where these two are the chairman of Indian Resuscitation Council, Dr. Chakrao, and Dr. Rakesh Gar is the director, is the scientific director. So these two were called and congratulated because on World Restart Heart Day, out of 800,000 people resuscitated by training was given, and in India the training was around 500,000 was from India, that too by Indian Resuscitation Council. So that was another achievement which all of you should know. So basically, ILCOR, what does it do is it provides the science, and various organizations update their guidelines. So the updation, what is seen is because of from the science which is provided from the ILCOR. Now this is the picture. You should know what is the principle. The heart is compressed between the sternum and the vertebra. Then what is happening also, you should see. Okay, it is very evident. You all will know that blood is pushed to the brain and other structures. When you release your hand, then the blood will come and refill in the heart for the next compression. So that's the principle behind this. Now, components of high quality CPR. Can you tell what are the components of high quality CPR? What do you know of?
Depth of the compression.
Yes.
It
What
should be
the depth?
It should be 5 centimeters or 2
5
inches.
to 6 centimeter depth, rate
100 to 120.
100 to 120 per minute. And here, this is AHA writes as 100 to 120 per minute. Indian Resuscitation Council Federation has written it as 120. The reason being, like if you tell 100 to 120, the range, the people will be doing, maybe doing around 100 or 120. And if you tell a value of 120, they will not come down from 120. So, see, here it is written 100 to 120. Both are same, and what Indian Resuscitation Council plans to is that it should never come down below 120, so that at least if they go to 100 also it's okay. So it's a 100 to 120 which has been told by AHA. Recoil, allow for the recoil, yes. Interruption in chest compression. And what else? Chest compression fraction. Chest compression fraction. So what is chest compression fraction from that side?
It is the proportion of the CPR, the chest compression in the CPR. That is chest compression time divided by the CPR
you
total.
describe it as a duration of the arrest. What is duration of the arrest? Duration of the arrest is once the victim falls down. That's the time from there to the return of spontaneous circulation. And what is chest compression fraction is the proportion of the time you have done chest compression. So if you have done for the duration of arrest is 3 minutes, and your chest compression you have done is for 2 minutes, 2 by 3, that comes to 60%. So what they say, like earlier guidelines say 60%. Now they are saying ideally it is 80%. Basically, it is to say that your coronary perfusion pressure should not go down. So avoid excessive ventilation, switch providers, all this, it's very evident. So in this picture, I would like all of you to tell me what is this. From the PGs here.
Defibrillator. Manual defibrillator.
That is defibrillator. This is defibrillator. What is it? It's coming to the pointer. You can see the pointer. See what. Okay, this is what I was asking. Yeah. Okay, that is a feedback device. That's a feedback device. What you have, like whether you have done it properly or not, whether the depth was okay, whether the rate was okay. So that's a feedback device. It cost around 1 lakh rupees. So that you keep on the patient and do. You have seen, you would have seen mannequins with feedback devices in them, but this is the actual feedback device which you can use. So you can see. So there are two types of monitoring. For the quality physiological data, that is how the patient is doing, and the CPR performance, how the rescuer is doing. So it is basic, and also the human supervision. So monitoring of CPR performance is by feedback devices. Okay. So you can see the results. So the first one, what is showing is that your depth is not adequate. Second one, which is showing that your recoil is not adequate. Third, it's showing that your speed of compression, that rate is higher. And the fourth one on the right side, what is above, what is showing the interruption time. Ideally, the interruption time from chest compression should be less than 10 seconds. Here it's showing 23 seconds. And finally, the mini brief, how much 98% your chest compression was adequate. 70% your rate was adequate. That is the percentage of the rate, and the depth is 96%. So that's how you can monitor. This is a video. What you can see, a person using, how they are using the feedback device. So he is keeping it above the chest and compressing onto it. And you can see the values on that. And finally, they do the debrief. And debriefing is nothing but the feedback. You give the feedback to the rescuers who are taken part and tell them this is what has happened, and this was your final data. So 97%, 77%, and 91% you were in 100 to 120 range. So that is what they think. So one of the drawback what they have studied by using this feedback device is they have seen this injuries. And what they have measured is like those who have done, what they have seen that those who have done for 2 minutes, that's 5 cycles, this is the stage with the feedback device. So this is not being used. Then coming to the physiological parameters. So one is the ETCO2, all this you will be knowing, and he has already spoken what is the advantages of ETCO2. Dr. Rajesh has pointed out about ETCO2. Can somebody say again? ETCO2, what are the ETCO2 and CPR? ETCO2 and CPR from second person. He has already spoken.
Sir, effective CPR
Yeah,
is
to know
told
the
on
quality of your CPR. So like if it is less than, ETCO2 is
if it is less than 10,
10, you will have to increase the quality. Okay, then confirmation of the endotracheal tube. You can use ETCO2. Then
when ROSC is obtained.
What is ROSC?
Return of spontaneous
Return
circulation.
of spontaneous circulation. There will be an abrupt increase in the ETCO2. So you can make out and what is the fourth one? There's one more use, which is not FDA approved. That is, you can predict the death of the patient. The decision when to terminate the CPR. If it is less than 10 minutes for more than less than 10 for more than 20 minutes with a non-shockable rhythms like systole or PEA, you can terminate. So that is the fourth one which you should all know, and he has already said what is the normal value. So what is this? Something related to CPR? It is surface cooling. So you do, that is hypothermia, induced hypothermia, or the present name is targeted temperature management. So what is being shown it is, and it is not done in all the patients, right? In which patient do you do it?
Post cardiac arrest care.
Post cardiac arrest, after return of spontaneous circulation, do you do for all the patients?
For comatose patient.
Comatose patient.
Comatose patients. So those who are not following the commands, then you will do. It is to decrease the metabolic rate and give rest to the brain. So that is the reason why you are not giving it for all the patients. Then cardiac arrest in pregnancy. What are the two important points like you should know about the cardiac arrest in pregnancy?
Left uterine displacement.
Yes. Manual left uterine displacement. Yes.
IV line should be above the diaphragm.
Okay. That's one more. When compared to the position, what is she said, there is one more thing. It is that. So what is more?
Perimortem cesarean
yes,
section.
perimortem cesarean
Uh,
delivery.
five,
That's called PMCD. So here, see, if you are not restoring the blood to the mother, you are going to lose 2 lives. So that is the most important. And as she has rightly mentioned, it is about the aorta caval compression. The gravid uterus compresses the greater vessels, and there will be aorta caval compression. So usually what you do is the lateral position, but you cannot do the cardiopulmonary resuscitation in lateral position. So what is advocated, and when should we do also? So ideally, when the fundus, the height of the fundus reaches the level of the umbilicus, that is 20 weeks. That is what they are saying. So after 20 weeks, then you should all try to do manual uterine displacement. You can check the height, and when it is at the level of the umbilicus, you should do. It can be done in 2 ways, either from the left or from the right. So if you are standing on the left, you have to put your hands across the midline, then grab the uterus and try to push it up and towards your left. So that is how you can do. You should continuously do it while doing the cesarean session also, and this is from the right. So care should be taken when you are standing at the right and pushing it, because it can be pushed down and further increase the compression. So there is a study by Dr. Pankaj Kundra. This is one of the papers which American Heart Association has quoted about the manual uterine displacement for cesarean section. That was way back in 2007. So we should all be proud that they are quoting one of the Indian papers. So it's about the manual uterine displacement. Second thing, what she has mentioned is perimortem cesarean section. So why are you doing perimortem cesarean section, PMCD? Why do you want to do it?
To save the neonate
Save the
in fetus, I mean neonate.
any other answers? See, the priority, as you all think, it is not the fetus, it is a mother. Yeah, you wanted to say something?
For the safety of mother, so that to maintain the effective CPR.
Effective CPR. Say, like when the gravid uterus is there, the heart will be pushed up, diaphragm will be pushed up. You will not be able to give a high quality CPR. So that is the reason. It is to facilitate the maternal resuscitation, and also to prevent the neurological injury to the fetus. So that is one. Where will you do it? It should be at the site of the arrest. Then who should do? Experienced provider, you should know. Then how? Whether it should be a vertical and fan still. What's your opinion?
Vertical.
Huh? Vertical is the classical one. See, what they have said earlier, it is classical. So classical, because it's very easy just to cut open the abdomen and take out the baby. So what is happening? Happening later, after 5 years when they studied this, the time taken by the present gynecologist is much more when they are doing a vertical, because all of them are accustomed with fan and still. So what they say now is you can either do vertical or fan and still, because the time taken to delivery is taking much more time when the present gynecologists are doing it. So that is the reason why they say either one of this you can do, and when you should do, it is within 5 minutes. So within 5 minutes you should try to deliver the baby. So as I told you, one is about the electrical therapy, which most of you, not most of you, like many of us are ignorant of what is happening. What is the rhythm? What is going on here?
Atrial flutter.
Atrial flutter. Why do you say it is atrial flutter? It's good, right?
Sawtooth.
Sawtooth, classical sawtooth appearance. So you can see the atrial contraction, much more contraction, almost 3 to 4 in that. And it can be regular or irregular. So that's the atrial fibrillation, you are right. And all of you would have heard these things: defibrillate, cardiovert, and pace. How many of you have done all these three? Can you show hands? All the three? Witnessed all the three? What about the first two? First two? The first one? Done? Done. Okay. Then two, it is very less. Okay. That is the reason why I thought of speaking to you about this. So I will be talking on this defibrillation, cardioversion, and transcutaneous spacing. So defibrillation, it is delivering an electrical current to stop the abnormal rhythm. It is not to stimulate the heart, as many of you think. And later what happens, it resets the electrical system and allow for the return of the normal rhythm if it is working properly. So that is what defibrillation means. So what is fibrillation? You are stopping it, that is defibrillation. So it is unsynchronized shock. What do you mean by unsynchronized shock?
Not in synchronization with the cardiac cycle.
Okay. Not synchronized with the cardiac cycle. So when you give defibrillation, what happens is it can fall in anywhere on the cardiac cycle. So it can fall on P, it can fall on R, it can fall on T. So that is unsynchronized shock. So synchronized shock, what is it called, synchronized shock? Synchronized shock?
Cardioversion.
Cardioversion. So the one of the main differences, it is unsynchronized shock. Unsynchronized shock. And it is for the treatment of life-threatening cardiac arrhythmias. So what are the fatal arrhythmias you know of? So what is this?
VF, ventricular
Pulseless electric.
Ventricular fibrillation. Yes, exactly. There is no, it's right, there is no morphology at all. And what is this?
ventricular tachycardia.
Can you be more specific?
Pulseless ventricular tachycardia.
No, that you check the pulse and see. No?
Monomorphic.
Monomorphic, yes, monomorphic tachycardia. And this one? Polymorphic tachycardia. So why it is called monomorphic? Because look at the shape, it is all uniform, and here it is not. So QRS is wide and it is irregular. So that is polymorphic VT. These two are the shockable rhythms. And other two, what we get is pulseless electrical activity, where we will have an organized rhythm, but there is no pulse. That is pulseless electrical activity. During our days, it was called electromagnetic dissociation, EMD. Okay. Now it's called pulseless electrical activity and asystole. So these are the four rhythms which will come in cardiac arrest. Fatal rhythm, and first two needs defibrillation, and the last two, those are, because they are the terminal rhythms, they are not shockable. Now coming to the defibrillators, I already have told you about this. If you classify defibrillators, it can be manual external defibrillator, manual internal defibrillator. How many of you have seen manual internal defibrillator? Can I have a show of hands? Okay, 3, 4, 5. Okay. An automated external defibrillator. So this is the manual defibrillator which we all used to have, and this is automated external defibrillator. What does it do? It identifies the rhythm which needs a shock, and it will give you voice prompts and tell you to give shock or not to give shock. So that is AED. The present defibrillators has all these incorporated into this. If you turn to one side, it becomes the manual one. If you turn to the opposite side, what you see on that white this thing, that is AED. It has a provision for transcutaneous pacing also. So everything is included in these machines. It can be portable. You can see it is kept on the on each cot. So portable ones are there, and that is the internal defibrillator. And you can see one picture where the heart is compressed, and now you can see the ventricular fibrillation. Now it is going to shock. How much joules you give for internal defibrillation? Those who raise the hands, any idea? Or it is 10 to 20 joules. 10 to 20 joules. So there are two types of defibrillators. One is monophasic, where the current flows in one direction only, and there is biphasic also, where the current flows in two directions. So the energy needed to suppress an arrhythmia in biphasic is lesser compared to monophasic, where you need more of the current. That is around 360 you need, where here you need only 200. And what they have seen is the first the first shock success rate in biphasic, it is around 90, and all the drawbacks are less with biphasic. That is why now more of the biphasic machines are coming. So an easiest way to identify biphasic and monophasic is by looking at the maximum energy, how much it is. And see, this is a monophasic one. You see on that is 360. If you see that, you can think, you can take that it is a monophasic, and a biphasic in this is a biphasic machine. Here you find 200. But I was really surprised to see the hospital where I am working now has a defibrillator which is having 270. That's the biphasic. So you cannot completely rely on these numbers. You should always try to keep the manual handy. You should be familiar with your machine before itself. Then only you can use it. And this one I already told, monophasic is 360 and biphasic is 200, and that is the paddles what you are seeing. You can give the shock through the paddles and also through the pads. That is adhesive pads. Pads are always better. The impedance is much less. And in a cardiac arrest, if you have already put the pads, you can easily defibrillate within no time. But if you are using a paddles, each time you will have to take it from the machine and put it on the patient. So if somebody asks you which is better, it is the adhesive pads, and it is there is difference for the pediatric as well as for the adults. And where will you put it? There is anterior lateral position, which is very common, and also anterior posterior is also there. This is mainly for the children, so that both pads doesn't touch each other. So if you are using a pads, then all this charge button will be on the machine. Shock button also will be on the machine. But on the pads, if you look, there is that yellow, what you find is the charge button, and the other orange on two paddles, what you see is the shock button. So the charge button will be seen only on the right one, that is that apex one what we are having. So the steps, these are the steps which everyone knows. You have to power it on, you have to attach the pads or the paddles, attach the pads and the paddles. Then you have to analyze. When you are analyzing, you should not touch the patient, because the machine will think, if you are using AED, the machine will think it is a normal rhythm, and it will say it's a non-shockable, no need of shock. So you have to always clear. You should not do the compression while you are analyzing. Then if it is a manual defibrillator, you select the energy. If it is an AED, it will be auto selected, charge and clear and shock. So you can see this a small video on that, and he's applying the gel so that there will not be any skin burns. So you can see that is the charge button. You can charge on that. Then he's going to give shock after clearing. Then also you should not test the patient because the current should reach to the heart. So that is defibrillation, which most of you will be very much familiar about. Coming to the cardioversion. Cardioversion, it is synchronized. Where are you going to synchronize it? Synchronize. It will be synchronized on the
R wave.
R wave. It will be on the at the peak of the R wave, and it is for the treatment of unstable tachyarrhythmias. So arrhythmias, when it comes, you have to see whether these patients are stable or not stable. What are the points to say that stable is what is written? Those 5 points are there. What is shown there? Hypotension, altered mental status, signs of shock, ischemic chest pain, or acute heart failure. So if it is there, if these symptoms are there, you will directly go for cardioversion. If the symptoms are not there, any of the symptoms are not there, then you go for medical treatment. So like for the example, atrial flutter or SVT, you are going to give adenosine. For a monomorphic VT, you are going to give amiodarone. That is if there are no symptoms. But if there are symptoms, you are going to cardiovert the patient. So it uses a sensor to deliver a shock. That will be, it is synchronized at the R wave. And if you press the sync button, there will be a button on that sync button. So it prevents the delivery of shock onto the T wave. So what happens actually is when it falls on the T, there will be, it will induce ventricular fibrillation. So that is the reason why it is been, why it is synchronized. Another thing, what you should know, by like when you are using a cardioversion, it will take, there will be always a delay in delivering the shock. But if you are giving a defibrillation, you, with the defibrillator, it will deliver immediately. Why? Because here it is synchronizing. It will take multiple ECGs, the rhythms. It has to assess multiple rhythms to get synchronized. So that is the reason why there will be always a delay. So you will have to keep the pads for more time. And low energy, you should know that it's all low energy. Low energy, if it is not synchronized, it will definitely go for ventricular fibrillation. So when you are using low energy, you should be always synchronize and give. And these are the rhythms. What is this rhythm? Quick.
Atrial fibrillation.
So you can see the classical fibrillatory wave, and it is irregular, that is atrial fibrillation. This has already been told that atrial flutter. Supraventricular tachycardia, it is narrow complex, and the rate can go up to 250. So that you can do the cardioversion. Then this has been already told. Monomorphic VT and polymorphic VT. When it comes, usually it will not have a pulse. So definitely it is going to be a defibrillation for polymorphic VT. So the steps, what you have to say, remember about the 3 C's. You have to take a consent from the patient because patient is conscious. You have to tell him the procedure. Crash cuts should be ready because it can fall, or if it induces ventricular fibrillation, you will have to go for the advanced measures. The airway cart should be ready. Then consider sedation. See, I put consider sedation because these patients are already having symptoms. They will having hypotension, etc. So that time, if you are going to give more of the sedation, it will further make the patient deteriorate. So always consider and give titrated dose. It is midazolam, fentanyl. These are the drugs because it is painful. You will have to tell the patient. So remember about these 3 C's. Then turn the monitor on. So you can see how to turn it. Like if you turn to one side, it is defibrillation. Another one is the AED. Attach the monitor pads. see the position the pads, either anterior posterior or anterior lateral. Then press the sync button. You have to press the sync button. So where exactly is the sync button? You should know where exactly is the sync button. You press on that. Once you press on that, you can see, look for the markers. So you can see on the markers above the R wave, there are markers. Those are the synchronized markers there. So it is going to, it is synchronized with the R wave. Then you should know what is the energy used for all this. For monophasic and biphasic, simple thing to remember is if it is monophasic or biphasic for a SVT and atrial flutter, it is 50 joules. For monophasic, for monomorphic VT, both monophasic or biphasic, it is 100 joules. And for atrial fibrillation, if it is biphasic, it is 100 to 120 joules. And 120 to 200 joules. And if it is monophasic, it is 200 joules. So it is almost similar, only difference is the atrial fibrillation in both this. And polymorphic VT, as I told you, it is defibrillation. Then you'll have to press the charge button. You can see if you are using a pads, it can be from the machine. If you are using the paddles, it is on the paddles. So once it is charged, you select the energy. Then you will have to charge it. Once it is charged, press the shock button. So you can see the shock button, that yellow button, not the orange buttons are the shock buttons. And on the machines also you can see the shock button. And you continue continue giving cardioversion if the tachycardia persists. So this is another machine. What I am going to show is a video on cardioversion. So this is the machine which is being used. Here you can see the defib part. Then the sync button is there, and also the energy select and shock button. So let us see. So first you have to attach the pads that is been attached. So anterior lateral position, you can also choose anterior posterior also. You should know where exactly it been put. It is below the clavicle and right side of the sternum, one. The other one is the mid axillary line or at the apex. So now you can see the rhythm, what is there, that is atrial fibrillation. So what is going to do is press the sync button, so you can see the markers on that. So then you will select the energy. Now what is selected is 120. If you use 120, and if it is not controlled, then you will have to increase. The maximum what is increased is 200. So he has put it 200, and now it is charged. And first you have to say clear and give the shock. So this is the rhythm. Now we can see like it is getting corrected. Okay, that's about the cardio version. So now coming to the transcutaneous pacing, either like unlike defibrillation, cardioversion, where it is to stop the abnormal rhythm, here transcutaneous pacing is giving a stimulus to contract the heart. So that is the difference. Transcutaneous pacing, exogenous pacing unit, it delivers an electrical impulse to stimulate the heart, and it induces a propagating wave of action potential. The goal is of temporary pacing is to improve the hemodynamics until the actual one that's a transvenous pacing or the permanent pacemaker is been put. So indication, treatment of symptomatic bradycardia, and those bradycardia which is not responding to atropine, and also you can use intermittent overdrive pacing, where there is a tachycardia, you are trying to increase the rate more than that intrinsic rate, then going to suppress. That you can use there also. Otherwise, mainly it is used in symptomatic bradycardia. These are the 4 rhythms. You all know that the first degree block, where there is increase in the PR interval. Second degree type 1, there is progressive prolongation of PR interval, which is followed by a drop beat. You can see the drop beat. And the type 2 is PR interval is constant, but there is a drop beat. And the last one is the complete heart block, where both atria and when there is no relationship between P or QRS. But all the P to identify is, you can identify by looking at all the P's, it is regular, and all the QRS, I'll just take 1 or 2 minutes. All the QRS, it is, all the QRS is also regular, but they don't have any relationship. So that is third degree. So what you see on the first one, yes, tell me what is it? That is, if you look at it, it is a progressive prolongation of PR interval followed by a drop beat. So that is type 1 of second degree block, and the second one is about the complete heart block. So these are the units what you have. Applies the basic electrodes. Then this, you know, like it is written front and back. Either you can place the one which I said in mid axillary line in V3 position also. All these are demonstrated on that. Turn on the monitor to pacing mode. So here you can see where exactly is the pacing. That what is written 1 is the pacer on. Then select a rate. Actually, how much you want to pace. What is the rate? Now what was seen here, it is 40. The rate was 40, around 40 for this patient. So you make it 60. You start with 60. For that, on the left side where you can see the pacing rate, you can either increase or decrease it. Then increase the current. That is what which is shown in below. That is about the current. To increase or not, you increase the current until you get a pacing for each P. There is a QRS. So just look at this video. So the rate is what you are seeing is 48 now. And it is a second degree block what you are seeing. Already the pads are applied. Now is turning to pacing mode. You can see the mechanical capture. The lines what you are coming is the mechanical capture. There are two types of capture. This is the electrical capture, sorry. There is mechanical capture also. You say mechanical capture when the P is followed by a QRS. So this is electrical capture what you are seeing. Now what is doing is increasing the rate. He wants a rate to be 100. So that is what he has done. Now he is slowly increasing the current. Say around 60 has increased. And see whether all the P is followed by a QRS. Now it started coming. So that is the mechanical capture. So when you get the mechanical capture, that is the current what is needed. You can increase by 2 milliamperes. So that's how the pacing is done. So that's all. Thank you very much. And the defibrillation, what you have to know is a high energy unsynchronized shock. Cardioversion is a synchronized shock. TCP is, unlike the other two, it is an exogenous stimulus to make the heart contract. What defibrillation and cardioversion, it is not. It is to stop the abnormal rhythm, and the best result is when you are familiar with the machine what you are going to use and use it within no time. Thank you very much.